I am proud to introduce our first speaker, Dr. Richard Camicioli, who's going to be speaking on the cognitive impact of Parkinson's. Dr. Camicioli is a professor of medicine at the University of Alberta. His research interests relate to blood, gait, and neuroimaging biomarkers associated with the cognition and functional decline in aging and Parkinson's disease. He is a member of the executive committee of the Canadian Consortium on Neurodegeneration in Aging. He is a co-applicant on C-OPEN. He serves on the Parkinson Canada Research and Scientific Advisory Board. His current studies are examining risk factors and their modification in Parkinson's disease and mild cognitive impairment. He has over 250 research publications. Welcome, Dr. Camicioli. We're so happy you're here.
Hi, can you hear me and see me?
I can hear you.
Perfect. And can you see my slide?
Yes.
Perfect. Really good. So thanks for inviting me and thanks for agreeing to or asking me about this topic. I think the day looks really fantastic. I think I saw already some questions in the chat about sleep, and there's going to be a talk on sleep, and then certainly younger onset patients and genetics are becoming more and more understood. And I think we're really in for a treat with Dr. Korkos. And I'm a collaborator with him on our high intensity versus moderate intensity exercise study. So I'm going to talk about cognition. So some of the slides are very sciencey. I can't see the questions when I'm presenting, but definitely when we're done the talk, we'll have time for questions. So we'll dive right in. So the goal, okay, there we go. First of all, land acknowledgement. I'm on Treaty, I live on, and I'm privileged to work on Treaty 6, which is the land of many First Nations, Métis and Inuit. And I know that Alberta has various areas that we are privileged to live and work in. So we'll talk about cognitive impairment, and I'll put it in the context of aging, and then obviously get into Lewy body diseases, of which Parkinson's is the most common. And we'll talk about the whole spectrum of what we see in terms of cognitive changes, and then talk a little bit at the end about motor and non-motor impairment and how to intervene, which is, again, what we want to do. I think you've already gotten the message that exercise is really important, and I would say that'll be one of our bottom lines at the end. So as people get older, there are many people stay okay and maintain cognition. In fact, some areas of cognition, such as language and vocabulary, remain very good and, in fact, can improve as we get older. But some people develop cognitive impairment. So changes in thinking and particularly people notice memory problems that is beyond what we would expect as normal. And then some of these people will progress and have more problems that are bad enough that they interfere with everyday activities. Can be taking your pills, can be driving, can be planning and organizing. And that's the definition of dementia. And people with Parkinson's are at risk of both mild cognitive impairment and dementia. That's sort of where we are trying to kind of figure out how to prevent this from happening. So if you look at just overall population, about a quarter of people over the age of 80 can have mild cognitive impairment. So when people with Parkinson's disease are again, this is not everybody. But a quarter of people with Parkinson's disease, even at this time of diagnosis, may have mild cognitive impairment. So kind of higher proportion than we see in the general population. And then the increase mild cognitive impairment increases with age. About a quarter of people over 80 will have mild cognitive impairment, and half again will have dementia. So about half of people over the age of 80. So it is part of what we see as people age. And again, it's sort of a real public health mission and of course a personal mission to try to see if we can prevent this from happening. So again, this is kind of putting it in the overall context. People who age can notice changes in their thinking. They can have minor changes in motor function, so slowing in walking, those kinds of things. Behaviors can sometimes be, again, these are kind of signals that this is not a normal aging, can have things like mild behavior problems, agitation, a little bit of aggression, sometimes that's out of character. Sleep changes, which are really important. And again, it's good we're having a session on sleep. And what we call autonomic changes, this changes in your regulation of blood pressure, changes in bowel and bladder function. And smell can actually change with age. And again, it's something that's associated with risk of cognitive decline. So all of these things in bold are things that, if they're happening in the context of cognitive decline, are really concerning because they kind of are a predictor of progression. And on the right, I show a slide where a colleague, Joe Verghese, did a study where he followed people over time and actually measured their walking speed and found that people who were walking slower than normal, they actually kind of defined that walking speed, usually less than a meter per second, were double the risk of developing mild cognitive impairment if they had subjective cognitive impairment, and twice the risk of developing dementia if they usually progress through a mild cognitive impairment stage. So the mobility aspects of aging, which is sometimes Parkinson's disease, is really important to recognize. This is more for, like, if you're noticing slowing and walking, talk with your doctor, try to figure out what's going on. Now I highlighted some of the other aspects that are specifically associated with progression to Parkinson's disease or dementia with Lewy bodies, which I'll talk about later. So fluctuating cognition. So people who have really staring spells, lose train of thought in conversation. Those are a couple of the things you notice with somebody with fluctuating cognition. So not only just noticing some changes in thinking, but if it's sort of kind of good and bad and good and bad and really changing from time to time, that's actually really a specific thing that makes us think of Lewy body diseases. Parkinsonism, where, obviously tremor, stiffness on examination, slowness of movement. So that's what we term Parkinsonism. And again, if you have that, that is a risk factor for somebody with mild cognitive impairment progressing. We talked about behavioral changes on the previous slide, but specific things that we sometimes see in people who are maybe developing at the prodromal stage are things like just less interest in doing things, anxiety, depression that wasn't there before. And rarely, we sometimes have people who have hallucinations, seeing things that aren't real. And again, of course, once you're on treatment, sometimes that comes out as well. And then in terms of specific sleep changes, somebody had mentioned in the chat daytime sleepiness, and hopefully that'll be covered in the next talk. But a specific aspect that makes us worried that somebody might be developing Parkinson's is REM sleep behavior disorder, acting out dreams, kicking and screaming in the night. And then finally, some autonomic changes, urinary symptoms, blood pressure drop, and loss of sense of smell. We have little smell tests in clinic because that helps us know this is a change that may be related to Lewy bodies, which again is what we find in the autopsies of brains of people with Parkinson's. So these are things you can see even before the motor stuff becomes obvious. So sometimes that's really challenging for diagnosis. So that's sort of the message here. There's some specific things that if you ask the right questions and notice the right things, that can help us be more confident that changes that you might see physically, like Parkinsonism or gait changes, might be related to the development of a Parkinson's-like problem. This is actually a slide looking at people who have acting out their dreams. And Dr. Josa, who's actually now on our faculty, he's a neurologist who's got an interest in sleep and its impact on Parkinson's and related disorders. And what he did was this: they had data from a large number of studies, and the red line shows worsening of the Parkinson's rating scale. And there's a purple line that also shows worsening of the Parkinson's rating scale. And the people had in the red line, over time, they all had REM sleep behavior disorder, over time developed Parkinson's disease. And the people with the purple line, their motor function worsened over time as well. But if you look at the actually, I flipped it. So the purple is Parkinson's and the red is people with who develop dementia with Lewy bodies. They're cognitive people who develop dementia over time first. This is before they had obvious Parkinson's, had worsening of their Parkinson's. So this sleep disorder is really important. It's treatable with some medications. It can have having trouble with sleep can be many causes. So again, hopefully more detail in the next talk. So Dr. Josa is actually studying people with REM sleep behavior disorder, and I've convinced him, and I think he's interested in studying people with Parkinson's who have these sleep disorders too, and seeing what happens with them. Dementia with Lewy bodies, I mentioned that term. It's really when the Parkinson's features and the cognitive impairment really happen around the same time, within a year of each other is the definition. And they are characterized, people with these problems have fluctuating cognition that I mentioned, may have visual hallucinations, seeing things that aren't real. They have REM sleep behavior disorder, and obviously Parkinsonism, because that's part of the definition. And again, the pathology at the brain level is very similar to, it's basically the same as Parkinson's disease. So I kind of look at these as a continuum. Some people present with cognitive problems, some people would present with more motor problems, some people even can have REM sleep behavior disorder and just have sleep problems, but without having yet developed motor and cognitive problems. So we kind of have to look at it as a spectrum. And I think it's important to recognize things early because, again, as has been mentioned, there are things we can do to prevent progression. And so I think that's really our goal here. This is a study that looked from England. It basically followed people with mild cognitive impairment. So they weren't thinking Parkinson's or Lewy body disease, but they followed them people over time. They had about 500 people in their clinic who had mild cognitive impairment. So this is what I mentioned earlier, cognitive impairment. They're still functioning and independent. They had about 80% had follow-up. And of those who developed a dementia, so this is where the cognitive impairment was worse over time and it interfered with everyday activities, about 20% developed dementia with Lewy bodies, and 100 people developed Alzheimer's, and some people remain stable. So that's actually an important message in people with, even if you're noticing cognitive concerns, you can remain stable. And so that's the goal. I mean, obviously don't want to, you'd like to get better, but staying stable is very important. And we're at the end, we'll sort of talk about some research looking into that. So people who developed a Lewy body dementia, and some of them could have been called Parkinson's disease, were predicted by when they at the first visit, if they had cognitive fluctuations, that have REM sleep behavior disorder, Parkinsonism, if they had more problems with visual processing and kind of thinking of things, having things come up. So coming up with words beginning with a letter of the alphabet, and then relatively better memory. So again, sometimes it can be very weird to a physician who hasn't seen many people with Lewy body related disorders saying, well, your memory's okay. You can't have a dementia. You can, it's just a different kind. And it's in sort of in our ballpark. There are some tests available. So I'll talk a little bit about tests, because all these tests can be used in early diagnosis of Lewy body disease or Parkinson's disease. So the changes in attention and visual processing, we see that as Parkinson's disease progresses. I'll show a slide showing that. The sleep disorder is actually the history of acting out your dreams in the sleep is very good, but again, there's other things that can cause waking up at night. So sleep history and sleep examination is really important. You actually see changes in the heart in people with Lewy body disease and with Parkinson's disease. It's denervation of the heart, so the heart can't go as fast as you might want it to when you need it to do that. And then you can see loss of dopamine in the brain. And then obviously there's some EEG findings that fit with the cognitive fluctuations, and there's some PET scanning findings. Having said all of this, these are the findings that you might find in somebody with either who's going to develop Parkinson's or Lewy body disease. We can actually be pretty confident of things by our history. This is what, if you ask the right questions and you do the right physical exam, you don't really necessarily need to do all these tests, but sometimes it's hard and subtle. So we do have some of these tests available to look at. And that contrasts with Alzheimer's disease, where memory and naming really are affected early on. There's some proteins found in the brain called tau. We can actually do spinal fluid, and now actually coming online are blood tests for Alzheimer's disease. So if somebody had Parkinsonism and cognitive impairment, we can pretty much say you do or don't have Alzheimer's disease at the same time. And there's shrinkage of parts of the brain that are specific to Alzheimer's disease. So again, these are the studies I just mentioned. Dopamine imaging, it may not be useful early, and it kind of relates to how bad the Parkinsonism is. The PET, especially looking at metabolism in the brain, not really useful. They're very hard to differentiate. MRI, again, the less shrinkage of the hippocampus in Parkinson's than in Alzheimer's, but you usually have a history that's very different. The spinal fluid, again, some people can have both things going on, so maybe useful in some people. There are now tests that are kind of coming online in the spinal fluid. They're not yet available in blood to actually say this person has a synucleinopathy. Synuclein is the protein we find in Lewy bodies. So these can be useful to differentiate people with Parkinson's or dementia with Lewy bodies from other things. And these are fairly good tests. Again, I was at a seminar this week where they are available. They can be sent out. But again, I think the message is a good clinical assessment. You don't need these tests. You can actually give some confidence in what's going on. And then there's blood markers, but they're not there for us here at this meeting today. So the diagnosis of Parkinson's is based on the presence of rest tremor. Typically, not everyone has it. Slow progression. Rapid progression makes us think of more infectious and inflammatory things, and those are really important to assess quickly. People on treatment for Parkinson's can develop dyskinetic movements, hyperkinetic movements, and then early in Parkinson's, we say if you have dementia, like in other words, if you have dementia at the same time, we just call it something different. We call it dementia with Lewy bodies. Marked blood pressure drops are seen in another Parkinson's plus disorder. We call these Parkinson's plus, multiple system atrophy, for example, but you also see it in Parkinson's. Eye movement problems are seen in PSP and MSA, multiple system atrophy and progressive supranuclear palsy, and early falls are not typical of Parkinson's disease. So again, these are red flags that you really do need to see specialists and kind of figure out what's going on. And then some pyramidal signs, these are the signs you might see after a stroke, but we can also see them in disorders like multiple system atrophy. Of course, nobody's immune to having two things going on. So people with Parkinson's, and I think I'm going to slow a slide coming up, can have stroke-like changes in their brain. Everyone has high blood pressure, everyone has diabetes. These are common problems and not everyone has it, but they're common. And so these are risk factors for other things that can give signs. So again, important to have an assessment. And then typically people with Parkinson's respond to levodopa. People who have the cognitive presentation, so dementia with Lewy bodies, you can still improve with levodopa, but the problem is the side effects may be a little bit more. And then other features like cognitive impairment, I mentioned, can occur early in Parkinson's. Smell loss, very useful. Some of the neuropsychiatric things I talked about, REM sleep behavior disorder, and the autonomic features. So this is a picture of a Lewy body. They kind of look pretty, but I don't think we want them. So we're hoping that someday we'll get rid of them. This is just how that synuclein test works. You kind of throw the spinal fluid into a test tube and you throw a little seed of a little bit of synuclein and it kind of binds together very quickly and it changes the color of the test tube with a spectrophotometer. So again, very good and very good at distinguishing. I just showed Parkinson's distinguished from the other disorders, but dementia with Lewy bodies also shows positivity on these tests. So they're a bit technically difficult to do, but they're doable, and so I think this may be helpful down the road. The blood tests are again a little bit of more of a challenge. So again, back to Parkinson's disease. So if you have Parkinson's, we talked about you could have more or less cognitive impairment. So cognitive decline is something that we see in some people. So if you have PD, the risk factors for somebody, so things that make me more worried about somebody who might progress to having more cognitive decline are older people, so people over the age of 70. Some kinds, I mentioned the motor problems we see. So if you don't have that asymmetry, often early on people present with one side more than the other. If it's both sides affected at the same time, that makes us more worried about progression. Walking problems in the setting of Parkinson's disease, early falls. So I said early falls to make us think of other diagnoses, but if you do have early falls and you have Parkinson's disease, that's concerning. And then blood pressure drop. I mentioned this specifically. It's again, we found in a couple of studies that we did following some people who volunteered for research here in Edmonton, that if you're older, had a drop in blood pressure and cognitive decline, you're more likely to progress to dementia. REM sleep behavior disorder has always also been found to be one of those features, and hallucinations also one of these features. And then Parkinson's and really all aging and all of us have a genetic background. So in people with Parkinson's, males are more likely to progress to cognitive decline. There's some genetic subtypes that are associated with progression. And then we all have a background of education, level of physical activity. Head injury is really important to avoid no matter what. There's more evidence of environmental toxins contributing to the risk of Parkinson's, and less is known about the progression from Parkinson's to cognitive impairment, and certain dietary patterns, which I'll talk a little bit about. This is an example of the visuospatial problems that you might see in somebody with Parkinson's. This is from a research study we did that I'll actually show some imaging from. So if you ask somebody to draw a clock, you know, most of us do a decent job. I think we're asking the person to draw 10 after 11. So it's not a perfect clock. It's not bad. You can see the shape, you can see the distribution of numbers, and actually but you can also ask the person to copy a clock. So what we found was that if you copied a clock, you actually pretty much normalized in early Parkinson's disease. This is typical people on medication for Parkinson's. But as time went on, that copy did not improve, and the clock gets more and more distorted. So this is what I mean by visuospatial impairment, and that actually can be a concern for driving, for instance. If this is how you're seeing the world in front of you, it's not safe. So it's better to kind of consider stopping before you have this kind of visual problem. This is the same group of people who were followed over time. And what we see, the yellow blobs on this, is where there was shrinkage of the brain. And that actually fits very well where this pathologist, Brack, showed that there was changes in the brain with Lewy bodies. These are the stained for Lewy bodies, and I show them in the middle again. And so that we can actually measure the shrinkage of the brain, even though there's not as much shrinkage as we see in Alzheimer's disease. There's very specific patterns of shrinkage of the brain. Unfortunately, this is a little bit subtle enough that we can't really use it as a predictive test. But the reason I did this project, it was like in the we finished in the early 2010s, was to try to develop tools we could use to sort of see if we can slow the progression down using treatment. So it's like a tool for monitoring treatments. Now, we've talked quite a bunch about Lewy bodies, and the other kind of common age-related pathology that, again, was accounting for 80% of people who with mild cognitive impairment who develop dementia are the brain changes of Alzheimer's disease. So as we get older, it's very common to have both kinds of changes going on. Again, if you have Parkinson's, you're kind of not immune to the changes of Alzheimer's. And these are PET scans that looking at the main protein in Alzheimer's called amyloid. Very bright in a patient with Alzheimer's, not so bright in a patient who's a healthy control, and similar in a person with Parkinson's disease with dementia. And what was found, again, this is an older study, but I kind of like it because it shows that if you have low amyloid, and you have low amyloid in the spinal fluid because there's more in the brain, it gets mopped up by the brain, which is kind of like a sponge for the amyloid. You're actually at very, you are at, but 50% of people will have cognitive impairment in 5 years. So that's a higher risk than 50% in 15 years. 15 years is far down the road, whereas 5 years is pretty just around the corner. So some people with Parkinson's have depositions that are like amyloid, that are like those we see in Alzheimer's disease. And people with dementia with Lewy bodies, where the cognitive presentation is more prominent, where people present with more cognitive impairment at the time of Parkinsonism developing, have more of this going on. And they actually may have a scan that looks a little bit more like Alzheimer's disease. I mentioned this, again, thinking ahead, there are actually now just approved treatments for Alzheimer's disease that can remove this amyloid protein from the brain. So will people with Parkinson's or dementia with Lewy bodies be candidates for these? Not yet, because we don't have trials, because there's high risks associated with these treatments. But again, looking optimistically, we may develop some treatments that may be useful. So I'm talking a little bit about vascular. So vascular changes are things like poor circulation to the brain. So degeneration is the progression of the disease. Vascular changes are associated with risk factors: high blood pressure, diabetes, smoking, high cholesterol. These are the main risk factors. So they may be important. And we see more vascular changes in people with Lewy body disease, including Parkinson's, dementia, and dementia with Lewy bodies. And these are associated with cognitive and motor changes like progression of walking difficulties. And they may be preventable. So it's important to see your doctors and make sure those other risk factors are dealt with, your general health. So you see the white spots, which are in red in the scan below. These white areas are, we call them white matter changes, and they are thought to be due to poor circulation to the deep parts of the brain. And they're more common in people with Parkinson's, with mild cognitive impairment, Parkinson's, Lewy body disease, a little bit less in Parkinson's disease. That's closer to the control group. So they're there in people's brains, and they are associated with progression of cognition and progression of walking problems, especially. And we actually showed in this study that this white matter changes were associated with freezing of gait. So some people exhibit freezing of gait where you can't initiate steps, or when you're turning, you have shuffling. And we found that was associated with white matter hyperintensities, those white changes that I showed you just now. But they were also associated with Alzheimer pathology in the CSF, which again, I just showed was associated with cognitive impairment. And what's thought to be, it's thought that these can directly lead to freezing, the white matter changes, the amyloid changes, but they increase the risk of white matter hyperintensities. How does that happen? Amyloid is found in the brain tissue. That's what the PET scan showed, but it's also found in blood vessels and can affect the circulation. And I already mentioned that people with Parkinson's may have autonomic dysfunction. So the blood pressure may drop and may be hard to control. So something, again, another reason to pay attention to your risk factors. So this is a slide showing showing maybe a caveat to, you don't want the blood, you want it low, but you don't want it too low. So in the red circles, this study, what they did was they tested people lying down, memory, and they planning and organizing ability, visual processing, and they found that if these same people stood up and their blood pressure dropped, they did worse on these tests. So again, in terms of we have a preventable direction, so we can treat high blood pressure, diabetes, cholesterol. But if we treat the blood pressure too aggressively, we may be leading to lower cognitive function. So one of the things I always worry about or think about when somebody has cognitive complaints in Parkinson's is, how's your blood pressure through the day? So monitoring and getting kind of a tool at home where you can monitor your blood pressure is kind of a useful thing to keep in mind. Again, levodopa, the medication that helps movement, may lower blood pressure. So sometimes we have to balance it, cutting back on the levodopa or adding other medications or other strategies to deal with lowering the blood pressure. So I pay particular attention to. You can imagine, let's say in the morning you're feeling good, and then later in the morning you sort of feel really, I'm not thinking straight. You know, that sounds like a cognitive fluctuation, but it could be simply related to your drop in blood pressure. So it's something to keep in mind. What happens to the brain and with the blood pressure lowering? So we participated in this study where we looked at the blue is people with no blood pressure drop. The dark red is the people with a severe blood pressure drop. We found that the people with severe blood pressure had some greater shrinkage of the brain in various areas and more atrophy overall. And then the ones with severe blood pressure drop did have more white matter hyperintensity. So that actually even could be contributing to the problem down the road. So again, careful management of blood pressure becomes something that could be preventable, that lead to preventable aspects of cognitive impairment. So, I mean, we've talked about cognitive impairment. We kind of know what it is. We kind of talked about a little bit of the basis. So why bother? Well, I think it's better, in people with cognitive decline, it gives us a better idea of that there may be need for help down the road. So why not kind of start anticipating these things? Obviously, these are associated with, well, not obviously, but these are also associated with falls risk and increase your risk of mortality. So what do you do? So kind of knowing that what the changes in thinking that are there are real, what they're like, offer support. So people may need more support. If you can't, for example, take your pills, using a pill box or having somebody help with that is really critical. Now, we just talked about other risk factors, other diseases that may increase your risk of progression. So, but if you're forgetting your pills, you need more help with monitoring. So that's really another sort of aspect of things. Health and wellness. So I'm going to end this talk about talking about you can do things, and some of them have been alluded to earlier, to improve your health, improve your wellness. Socialization is important. Exercise is important. Sleep is important. So these things can become priorities. They should be priorities all along, but let's say you haven't had them as a priority, it's never too late. And then obviously if somebody with cognitive impairment, we mentioned problems like visual hallucinations that can occur. Recognizing for your family to recognize and you to recognize these are not, something that you're just making up. They're part of the disease and potentially treatable. The other thing, I told you that visual processing change over time in a patient. Worry about safety, including driving, weapons, and tools. And again, sometimes one has to, there are losses, but a loss where you kind of prevent an accident from happening is really a gain. And obviously, and the other thing is planning ahead. So personal directives, advanced care planning, and finally, treatment, including we'll emphasize cognitive and social engagement, nutrition, and exercise. Again, specialists like occupational therapists, physical therapists, exercise therapists can be helpful in this. And this is a slide from a study from the Netherlands where they looked at if loss of independence was associated with increased was highly at risk if you had cognitive impairment. If you don't have cognitive impairment, really not much change in independence. So although we think of Parkinson's as a physical disease, and people with dementia with Lewy bodies also have physical changes, the cognitive changes are really important to pay attention to. So what are the I gotta just sort of So how and when to identify? I kind of was thinking about, when is it? Well, if you're noticing a change, I think it's worth having that assessed. Again, assessed with an expert that knows what's going on. Psychologists or geriatricians, neurologists, psychiatrists. Exclude and treat neuropsychiatric issues. Now, I mentioned earlier that anxiety, depression, psychosis can even precede cognitive decline, or it can be seen, especially depression and anxiety, as we call a prodromal, even before you can diagnose Parkinson's disease. Doesn't hurt to treat these things. So anxiety can be treated with medications and counseling and cognitive behavioral therapy. Similar with depression. If people are having hallucinations, seeing things, again, recognizing this is part of a disease process, not something they're just making up, and taking it seriously and treating it. So that's another reason to kind of have an assessment. Change in baseline on a screening test. So we do some screening tests. For example, the common one we use is the Montreal Cognitive Assessment Battery, which is a short test that we monitor regularly in our movement disorder clinic and obviously in my cognitive clinic. And so it's important to kind of get a baseline test, and if there's a change over time, that's important to recognize as a reason to kind of pay more attention to things. And then finally, if function is out of keeping of the motor. So we see people, and some people have lived through this, where motor function is okay, but it's really hard to do things. And that could be on a basis of a cognitive problems. And then neuropsychological testing is kind of the gold standard in terms of testing in people with Parkinson's. Not super widely available, but in the right circumstance, let's say somebody says, I'm really noticing something change, and we do a screening test and it's okay, and there's really no depression or anxiety, or they're treated. This is a useful tool to kind of detail where in the pattern of thinking that there are changes. And as I showed you earlier, the details may make a different, may differentiate different things like Alzheimer's from Parkinson's. We did a study we're just working on. A great summer student, Alexandra Loverock, worked this summer on a study where we took our new research group, which is the Compass ND cohort, and looked at different cognitive profiles in people with a range of cognitive disorders. So we look at memory, executive function, processing speed, whether the words come back, visual spatial problem, language, and social cognition, and showed that people with Parkinson's with mild cognitive impairment, this is the purple group. I like purple; it's a good color. Had more problems in a number of domains, including visual spatial, which we kind of expected, language, which we kind of didn't expect. So word finding, coming up with the words were affected, and I think that's probably, we didn't expect it, but kind of when you think about it, it makes some sense. So people with Parkinson's disease with mild cognitive impairment had more problems than people who had mild cognitive impairment on another basis, although the people with non-Parkinson's related mild cognitive impairment had memory problems. So they kind of had more memory problems, as did our people with mild cognitive impairment with Parkinson's, and less problems in planning and organizing, less problems in speed, less problems in language, less problems with visual spatial. So again, we see a pattern. So this is where neuropsychological testing can actually be helpful in terms of differentiating groups. This is a research study, and we're now just trying to see over time. Well, we actually now just got the data over time, but we're trying to also see how this relates to blood markers of different and brain imaging markers. Again, one thing I want to mention, we mentioned that again, when recognizing that there's a cognitive change is useful to predict things, but it's also a good time to think about things like personal directives and advanced care planning. We did this study with a fellow, Dr. Miyazaki, and I, and the moving disorder clinic, where we looked at people with subjective or mild cognitive changes and gave them people some scenarios to understand. And it was harder to understand the scenarios of, what would you do and if you were offered an ICU, you had to go to the ICU for care, specific treatment decisions, comfort care decisions. Our conclusion was that it's really important to know that you have to take more time. So in a sense, the communication has to be more of a priority if you have cognitive impairment. And we would suggest that it's better to kind of establish a personal directive ahead of the time of you're having cognitive impairment. So what do we do medication-wise? You simplify medication. So levodopa is really the most beneficial medication. It actually mimics the compound we find in the brain. There are some medications for dementia in Parkinson's and dementia with Lewy bodies. Donepezil and rivastigmine are the two most commonly used, and memantine's one that doesn't work quite as well, but if you can't tolerate these, this can be used. You can treat REM sleep behavior disorder, and I think I'm a strong believer that better sleep will lead to better daytime function. And then there's some medications for hallucinations. Pimavanserin is not available in Canada, so we tend to use Seroquel or clozapine. Or sometimes when you simplify medications, consider the cholinesterase inhibitors, get sleep under control, the hallucinations can improve. And then people with advanced dementia who may have agitation and behavior problems, there are other medications that are kind of borrowed from Alzheimer's. So really critical to avoid neuroleptics. These are dopamine blocking agents. Seroquel and clozapine have the least dopamine blocking effects of all the antipsychotics, which are typically used for hallucinations. The other typical ones should be avoided because they can actually cause a profound decline in function. And then I'm gonna on the slide here, we show a picture of where the cholinergic system. So cholinesterase inhibitors increase acetylcholine in the brain, and there's shrinkage in that area and atrophy in that area in people with Parkinson's. And so you want to avoid drugs that block that system because that can worsen cognition. So typical drugs are things like oxybutynin, which is used as a bladder medication. And so that can lead to cognitive dysfunction. And there's certain other medications that are better that don't have cholinergic effects. Nutrition, I'll touch base briefly on nutrition. Some people have trouble swallowing. There's a lot of GI changes in people with Parkinson's. People, for example, with dyskinesia have a lot of energy expenditure. And then some people with cognitive and neuropsychiatric problems may avoid food or not eat as much. And so these are important to keep in mind. And then some vitamins, there's not a strong evidence for vitamins, but people with low vitamin D should have that normalized. Levodopa blocks the metabolism of some substances in the blood, and so B vitamin complex is suggested. And the Mediterranean diet is useful, which is lots of fruits and vegetables, lower frequency of red meat, more white meat and fish. These may show benefit in Parkinson's. The DASH diet is the blood pressure lowering diet. So if your blood pressure is too low already, you might have to take that into account. And we showed there was a blood lipid profile that differentiated people with Parkinson's who developed dementia from those who didn't. And these may give us new ways of treating this and preventing dementia. Finally, exercise. There's various kinds, resistant aerobic walking. You'll hear a lot more about this this afternoon. And cognitive benefits have been shown with a number of different exercises, but few people have used them in people who already have cognitive impairment. And then a combination with cognitive training might be an option. My colleague published a paper in 2023 in people with cognitive impairment and found that if you combine exercise with a cognitive training program, this led to the greatest benefit. the down bars are good in this picture, and then slow decline of cognition in people with mild cognitive impairment. And when we look back at the population of people who volunteered, about 20%. Remember, that was the 20% of people with mild cognitive impairment who could progress to dementia may have had features that suggested they were going to develop either Parkinson's disease or dementia with Lewy bodies. So we think it works in this population, and we're currently doing another study where we're recruiting people who have mild cognitive impairment, and we're kind of doing this as a home-based exercise training program. So the idea is to evaluate cognitive improvements with the home-based training program compared to an educational program, and looking at basically coaching for lifestyle, which the educational program will cover, and then we're evaluating the whether the risk factors show improvement in cognitive impairment, and cost effectiveness of the program, where you have coaching versus just your self-education. And these are the arms. We're sort of looking at the main outcome is cognitive decline, and then other things we're looking at are whether we make screening tests are better, whether vascular risk factors are better, whether quality of life is better, and then looking at what changes we see in the blood, and then obviously see if improvements are there with more sleep and things like that. So this is an 8-center study around Canada. We're at 450, so we're hoping to get over the finish line soon. We actually have recruited all our patients here at University of Alberta. We're hoping to get funding to continue, but we've started recruiting people with Parkinson's disease and mild cognitive impairment. And then it's a 12-month study. So and you're either randomized into the coaching versus the self-education. And these are the risk factors we look at. So people you have to have mild cognitive impairment, low physical activity, because if you're already doing a lot, that's good. Poor diet, if you're already good, that's good. So we screen, part of the work we're doing is we screen people, and if people are perfect, that's good. You're doing all the right things. So there's not much more to suggest, but we look at sleep quality, we look at vascular risks. Here's the vascular risks we look at. And the idea is we'll see what happens. And it's, again, 450 have already recruited. We've had a good uptake in clinic and actually through community recruitment for people with Parkinson's with mild cognitive impairment. And we think even in the people with mild cognitive impairment who haven't been identified as Parkinson's, there's about 20% who will have a Lewy body progression. And then this is just the intervention. It's exercise, cognitive training, diet recommendations, risk factor management, and then obviously some interventions on sleep, and it's 2 hours 3 times a week with coaching. So this is the end. What I'm going to, and with time for questions, I hope. This is a slide that I'll end with where it's thought that maybe if you treat various things early in life, you may prevent dementia. In Western societies, the dementia prevalence, the amount of people with dementia is going up, but the number of new cases is going down. And we think that they're going down because of these better adherence to life risk factors. And so this is for everybody, but this applies just well for Parkinson's. There's risk factors such as hearing loss. Everyone should be checking that. We talked about cholesterol, depression, avoiding traumatic brain injury, physical inactivity, diabetes, smoking, hypertension, obesity, excessive alcohol. These are things to avoid, which will prevent dementia. Social isolation. Again, I heard the testimonial about going to the Buchanan Center. Socialize, whether it's through your church, whether it's through your family, whether it's through programs in the community. Avoid air pollution. Hard to do, but it's something we need to try. And there's other pollutants that are going to be coming on this list when this is revised, and visual processing needs to be processed. So with that, I think I'll end with my bottom lines, but I think it's more important that we get a few questions in. I'm going to get out of my slides. I'll just double check that we've covered everything. We have covered everything. And then I'll just be here. And I think Brandy, are you or somebody's going to tell me what the questions are?
I'm here. So we've got some questions from the viewing parties and the online folks. So I'm gonna a couple of them together because they kind of go together. So one
Perfect.
says, How much of a blood pressure drop is considered concerning? And the second part to that is, what if you've always had blood pressure issues, even before Parkinson's? Does that change
High
it?
or low? I mean, I guess it depends on if it's high or low, but
Low.
yeah. So the good news is low blood pressure is good for preventing vascular disease. But we think that a blood pressure drop. So we have there's a kind of a scientific definition of 20 points drop in systolic from lying to standing, and 10 drop in diastolic from lying to standing. So there's a kind of a difference that we get concerned about. The other thing we get concerned about is if you have symptoms. So let's say you normally run 120, which is actually a good blood pressure, and you drop to 100 when you stand and you don't have symptoms. I'm not sure we're not 100% sure we need to treat that aggressively, but if you drop to 90, which is still in the normal range, it's a 30-point drop and you're symptomatic, like you're dizzy, lightheaded. And then the symptoms I think I was trying to get at is that they can just be like fatigue, kind of not feeling well. So I think it's 20 over 10, lying to standing. But if you have 20 over 10 sitting to standing, that's still, that's even more. We think that's even going to be more of a drop. And so, then we kind of again, you think about cutting back on some of the Parkinson's medications or adding medications or changing, like liberalizing salt in the diet, which is like not what you would do for a DASH diet because the salt is bad in the DASH diet. But if your blood pressure is dropping, then it makes sense to go up because that's the whole issue.
Okay. Is apathy linked to cognitive changes in Parkinson's?
Yeah. So apathy. So two things with apathy. One is if you're not interested in doing things and being with people, that affects socialization, affects, wanting to do exercise. So often it's really helpful if the family and the spouses and opportunities are made there for people. You might have to cajole them to do it, but it's still good for them. So yes, so one thing is it interferes with the things we know or we think will prevent progression of cognitive impairment, but it is also associated with cognitive impairment. It actually, you see apathy as part of, even you see it even in Alzheimer's disease, but it's a little even, my kind of clinical impression is it's more common in people with Lewy body or Parkinson's disease. So there's two aspects to that. So recognizing it, it's not like they're just being more sedentary. It's like part of the disease, putting opportunities to kind of prevent progression because you can have apathy and not have dementia. You can have just apathy and mild cognitive impairment. That's pretty common. But there's an opportunity to kind of potentially prevent progression to dementia where you become less independent. And 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 there's not a lot of great treatments for apathy apart from kind of creating some structure, getting people to do things. Sometimes apathy, it can be a non-specific thing, can be related to depression. So it's important to try to see, well, are you sad? Are you, are you depressed? And because then you would treat it as depression, recognizing that you can have both together, of course. But do you treat that what you can treat? And apathy, again, not a lot of medications. People have, like, actually, one of my very first projects was to try to use Ritalin, stimulants, to see if we could improve cognitive engagement. Found that we didn't really follow that study up because, again, studies are hard to do and cost money. But we did find that we could improve some aspects of attention and concentration, but didn't kind of follow it up to really know if it has an impact on apathy. So apathy is a really important thing to recognize and separate from depression and treat both in a sense.
Okay. There's more than one question that just says, I feel my cognition has started changing, or I feel my loved one's cognition have started changing. Does this mean they're going to develop the Parkinson dementia?
Perfect question. We don't, so some will, but some won't. So that's the whole thing. And I think we have less data on Parkinson's dementia and treatments that prevent progression of Parkinson's dementia, but we have the model from Alzheimer's, well, from MCI in general. And like I said, in that art and Dr. Montero Audasso's study that's published, we found that the physical engagement, the cognitive engagement slowed progression from mild cognitive impairment to dementia. And again, because I was interested, I asked for the data, or actually a colleague helped me get the data to say, well, how many of those would have been early Parkinson's. So they, mild Parkinsonism, REM sleep behavior disorder, maybe cognitive fluctuations, and some of them we actually do ask a history question of hallucinations. So they would actually be people who we think could be pre-Parkinson's or pre-dementia with Lewy bodies, one of the two. And that group was in there. So and that study worked. So I have, the next step, again, it's sort of on my to-do list, is let's say can we pull these out and actually look at that 20% and see if they did just as well or better. So one of the things none of the drugs that are used for cognition, we mentioned memantine, donepezil, have been shown to prevent progression to dementia in the regular world. They are used also in non-Parkinson's patients. But some people with Lewy body disease do really well with these drugs. So, maybe we're not picking the right people to respond to these medications. So there's a medication option as well. So exercise and cognitive engagement, social engagement, those are important and may prevent the progression. Some people will progress anyway. So that's why if you recognize it, it's a good time to sort of do advanced planning. So get things in safety measures in place. Take away all independence. But, if the visual spatial impairment is really bad, probably that person shouldn't be driving. Next.
Is there, I know it's complicated, but to distinguish between mild cognitive impairment and Parkinson dementia?
So dementia is when the functional, it's hard because if you've got a physical disorder, Parkinson's
Mhm.
disease, that slows you down, are you not doing things because you're slowed down and it's just motor, or is it because you're apathetic and not thinking to do things? So that actually really is difficult when because we've been studying this, I've been really interested in trying to figure this all out for years. So people have asked us, how do you know? Well, we kind of ask the person and their informant, their caregiver or their partner, what do you think? What's keeping them from cooking lunch, which they used to do? Is it because they're really having physical problems? We can work on the physical problems, or is it because, and again, not just medications, PT and OT to figure out what the barriers to that are, or do you think it's because they can't figure out how to cook that? And then that suggests it's more cognitive. So that's separating them is very, very challenging at times.
Is there so from a care partner perspective or a family perspective, are there things that the families or the care partners should be looking for as to when now it's starting to become a little more serious? Now we want to maybe look at some interventions or options.
Yeah. So so two parts to that. So those are really good questions. So one is if you're noticing it and it's getting worse, I think that's definitely you want to get into interventions. But I think again, hopefully Daniel will get that message. If we start doing things like exercise, socializing, partying with the community, advanced directives are planned before things are a problem. So if you're noticing, it could get worse, it could stay the same, could get better. But if you're noticing, why not sort of start implementing things? And that's, one of the things I actually looked, in preparing the talk, I was kind of looking to see what was new there. The Australian Neurologic Group, which was neurologists, geriatricians, and all that, they kind of had some guidelines, and they were suggesting it's actually kind of like what we do in practice. We do a baseline cognitive test, like a screening test, like the MOCA, and then you have that as a baseline, and you can follow it over time. And we in the clinic tend to do it every year or two, just based on, or if somebody notes a change. So if we know that somebody's MOCA was perfect, like Donald Trump's, oh, I'm going to be in trouble. But in 5 years or 2 years, let's say even we skip the 1 year, but 2 years later, start noticing cognitive problem has gone from 30 to 26. That's still normal range, but now that's a change. As I mentioned, you can have fluctuations, so you can do a 30 one day and a 25 the next day. But you can start saying, okay, well, let's see about simplifying medications. Let's make sure you're taking your medications right. Let's you're on a bladder drug. This bladder drug might interfere cognitive. Why don't we stop that and see what happens? So it makes it actionable. But I also always pay attention to what people are saying, what the spouse and the patient are saying. There's a change, and there's a change, again, can be subtle, like everyday activities, just how they are doing things are important.
But can you repeat that bladder medication that might be concerning?
Oxybutynin is the yeah. So the one that seems to have the least side effects is mirabegron now. It's
Okay.
a basically completely peripheral. All the other ones do have some central penetration. So in actually, we're lucky in Edmonton. There's a continence clinic run by Dr. Wag and Dr. Lee, which is really fantastic. And they're quite aware. And actually, Dr. Wag, Lee, and my colleague published papers who I'm forgetting his name. But anyway, they're really wonderful, and they're quite aware of Parkinson's, and they're quite aware of the right non-pharmacological interventions for urinary urgency and incontinence, and will avoid drugs that can worsen cognition. And actually, there's a lot of education around this too. So, GPs are also are educated in this realm. But again, a drug that might be okay in somebody who doesn't have cognitive impairment, doesn't have Parkinson's disease, and might help their bladder function, might not be okay in Parkinson's because of that cholinergic deficit that is on top of the dopaminergic deficit.
So I've got lots, but I'll do two more and then we'll kind of wrap up here. You mentioned hallucinations, and so are auditory hallucinations part of that? We've
So
got
yeah, most commonly it's visual. Sometimes it can be auditory too. So people, and I've actually been kind of fooled, with people who are noticing auditory hallucinations. We were wondering, could they be actual noises that they're having? But auditory hallucination as a change is or can also be seen. Um, some people with neuropsychiatric problems that are lifelong can develop Parkinson's too. So people with schizophrenia, their old drugs that used to be used for schizophrenia cause Parkinsonism, but now psychiatrists are using new drugs. So we had some patients notice that there's a difference between their hallucination, have noticed that there are differences between their hallucinations that they think are their schizophrenia ones from their Parkinson's ones. So I mean, I think so the hallucinations are definitely can be other non-auditory. I kind of that the fine print on that dementia with Lewy body slide, which also applies to Parkinson's, has and you can have non-auditory, non-visual hallucinations, but the visual ones seem to be much more specific, probably partly related to that visual processing change that I showed you with the clock drawing getting worse over time. So imagine if your brain's not seeing everything right, then things get distorted, and plus your thinking's not as organized, so you're not sure what things are. So that sort of can be part of it.
all right. So the last one I'm going to ask here is, if one is concerned about their cognition, should they be asking for a test? Would a PET scan help? Are there things
Yeah.
that they should be doing if they're concerned?
So I think the tests that can help are the cognitive tests, a history and exam, focusing on both the cognitive history, the psychiatric history, and then taking into account the motor stages, a review of medications. So I didn't I don't have a slide of this because it's a general audience, but in somebody who has a cognitive change, we usually check things like make sure they're not anemic, their liver functions are okay, their kidney functions are okay. If they're diabetic, how's that control? So there's a medical evaluation. Check their B12 levels. Again, we talked about B vitamins probably be not a reasonable thing to be on for everybody, but a B vitamin complex of some kind. So there's things you will test for. The imaging does not help as much. Now, I mentioned the vascular changes. So I've had a much lower threshold recently, lower threshold, like to do another scan. Like say somebody does notice a cognitive change or even a gait change. Remember, he showed gait is also associated with cognitive function. I'll re-image, like do a CT or an MR to just make sure we're not missing vascular changes. And we definitely have seen some of that. Again, that's not going to change the history exam part and blood work and sort of then recognize. And then what we do is we start simplifying the medication. So some of the dopamine agonists, for instance, can actually worsen cognition, worsen gait. So if you're on a dopamine agonist, not just leave a dopa alone, we might try to switch over. And that can take a little bit of work because you want to taper gradually. So there's no specific test. So for example, you can see PET scan change, the the Alzheimer PET that we showed. People can have amyloid. We know they can have amyloid, and knowing that you have amyloid was not going to change our management. So I think that the PET scan, it's more like rule out things you can treat and change. And the other stuff is still kind of research. How does it change whether we, like, again, I said that, the cholinesterase drugs didn't slow development of dementia in somebody with mild cognitive impairment. But there might be, maybe if you have a lot of shrinkage of that cholinergic part, or if you have amyloid in the brain, maybe that group would. But we don't know the answer to that question. So right now we kind of do the best possible.
Awesome. Well, thank you so much, Dr. Camicioli, for joining us today and for sharing your insight and knowledge. And everybody, we're going to take a 10-ish minute break here, and then we will be joined by Dr. Lucille Carrier. Thank you so
Very
much.
good talk. Listen to what she has to say too. Okay, bye.
Bye.